The primary tenet of manual muscle testing is that each muscle should be tested just proximal to the next distal joint of the muscle's insertion. The examiner must place the subject in positions that will isolate as much as possible the specific muscle or muscles being examined and eliminate substitution of agonist muscles. In the upper extremity, C5 can be tested using the biceps, C6, the extensor carpi radialis, C7 by testing the triceps, and C8 T1 by testing the hand intrinsic muscles. Lower extremity manual muscle testing includes testing the hip flexors, L2, the knee extensors, L3, the ankle dorsiflexors, L4, the great toe extensor, L5, and the ankle plantar flexors, S1. Upper extremity dermatomal testing involves testing C5, C6, C7, C8, and T1 dermatomes. The lower extremity dermatomes may be assessed by pinprick. The medial knee can assess the L3 dermatome, the medial lower leg, the L4 dermatome, the dorsum of the foot, the L5 dermatome, and the lateral foot, the S1 dermatome. Muscle stretch reflexes are elicited by a sharp, short blow with a tendon hammer delivered to the tendon of a gently extended muscle. Upper extremity reflexes include the biceps at C5-6, brachioradialis at C5-6, pronator teres C6-7 by tapping the distal radial styloid, and the triceps for C7-8 reflex. Lower extremity reflex testing includes the knee jerk, the L3-4 reflex, the medial hamstring, L5 reflex, and the ankle jerk, the S1 reflex. The Sperling test involves passive lateral flexion and compression of the head. A positive test is reproduction of radicular symptoms distant from the neck. The neck distraction test involves the examiner grasping the patient's head on the occiput and chin and applying a distractional force. A positive test is relief or reduction of cervical radicular symptoms. The Hermite sign involves passive anterior cervical flexion. A positive test is presence of electric-like sensations down the spine or extremities. Adson's test involves abduction of the arm with palpation of the radial artery, inspiration, chin elevation, and head rotation to the affected side. A positive test is alteration or obliteration of the radial pulse. The Tinel sign at the wrist is performed by the examiner tapping with a reflex hammer over the median nerve as it passes through the carpal tunnel. The test is considered positive if there is reproduction of paresthesias of the median nerve innervated digits. In Tinel sign at the cubital tunnel, the examiner taps the ulnar nerve as it passes just posterior to the medial epicondyle in the ulnar groove. If there is reproduction of paresthesias in the 4th and 5th digits, this is suggestive of an underlying ulnar neuropathy. In the Finkelstein's test, the patient's thumb is placed within the hand and held tightly with the other fingers. The wrist is then ulnarly deviated. If pain is experienced on the styloid process of the radius, the test is considered positive. The Phelan's test is performed by asking the patient to hold the forearms vertically and allow both hands to drop into flexion at the wrist for approximately 1 minute. Median nerve compression by this maneuver causes almost immediate aggravation of the numbness and paresthesia in the fingers. In the reverse Phelan's test, the patient is asked to keep both hands palm together with the wrist in complete dorsal extension for approximately 1 minute. If there is reproduction of numbness and paresthesias in the fingers, it is suggestive of carpal tunnel syndrome. In the Cozen's test, the patient holds the elbow extended and the wrist in flexion. The patient is then asked to perform extension while the examiner provides resistance. The patient should hold this position while the examiner continues to apply resistance. If pain is noted at the origin of the extensor carpi radialis, then this is suggestive of a lateral epicondylitis. In performing the resisted middle finger extension test, the patient is asked to hold the elbow, wrist, and fingers in full extension, while the examiner applies a force to the extensor surface of the middle finger. Pain localized to the lateral elbow is considered a positive test. In the resisted wrist extension test, the examiner has the patient hold the elbow and wrist in extension and applies a force upon the extensor surface of the wrist extensors. The patient is then asked to hold the wrist in extension. The test is considered positive if there is increased pain noted at the lateral epicondyle. The Yergenson's test is performed with the elbow flexed to 90 degrees and the forearm pronated. The examiner then resists supination. Pain localized to the bicipital groove is indicative of a positive test. The Speed's test is performed with the arm externally rotated and forward flexed against resistance with the elbow fully extended. A positive test occurs if pain is produced in the bicipital groove. In the drop arm test, the examiner passively abducts the patient's shoulder. The patient is then asked to slowly lower the arm to the side. The inability to return the arm slowly to the side is considered a positive test for a rotator cuff tear. In the empty can test, the arm is abducted to 90 degrees in the plane of the scapula and maximally internally rotated. Resistance is provided. If there is weakness and/or pain, the test is considered positive for supraspinatus pathology. In the Hawkins test, the humerus is forward flexed to 90 degrees with the elbow at 90 degrees. The humerus is then internally rotated. A positive test results in pain by the greater tuberosity impinging under the coracoacromial ligament. The crank test is performed with the patient supine, the arm elevated to 160 degrees in the scapular plane with the elbow flexed to 90 degrees. An axial load is placed along the humerus while glenohumeral internal and external rotation are performed. Pain with or without a click represents a positive test. In the Patrick or Faber test, the patient is placed in the supine position. The examiner flexes, abducts, and externally rotates the hip, with the ankle resting on the contralateral knee. The examiner then stabilizes the pelvis by applying pressure to the contralateral ilium. Pressure is then applied dorsally to the knee to further externally rotate at the hip. The test is considered positive for hip pathology if pain is localized to the groin, and sacroiliac joint pathology if localized to the lower lumbar spine. Gainsland's test is performed with the patient in the supine position, with the affected limb dangling off the examination table. The opposite limb is placed in flexion. The examiner assists with control of hip flexion while applying a downward pressure on the affected limb. Pain referred to the ipsilateral sacroiliac joint is indicative of a positive test. In the Ober test, the patient lies on their side with the thigh next to the table flexed to obliterate lumbar lordosis. The upper leg is flexed at a right angle at the knee. The examiner grasps the ankle lightly with one hand and steadies the patient's hip with the other. The upper leg is abducted widely and extended so that the thigh is in line with the body. If there is an abduction contracture, the leg will remain more or less passively abducted. In the Thomas test, the patient lies supine. The examiner flexes the patient's hip, bringing the knee to the chest to flatten out the lumbar spine, and the patient holds the flexed hip against the chest. If there is no flexion contracture, the hip being tested, the straight leg remains on the examination table. If a contracture is present, the patient's leg raises off the table. The angle of the contracture can be measured. The straight leg raise is performed with the patient supine. The examiner passively raises the affected leg. The elevation is stopped when the patient begins to feel pain, and the type and distribution of pain is recorded. The test is positive when the angle is between 30 and 70 degrees, and pain is reproduced down to the posterior thigh below the knee. In the cross-straight leg raise, the patient is supine. The asymptomatic leg is raised with the knee extended. The elevation of the leg is stopped when the patient begins to feel pain, and the type and distribution of the pain, as well as the angle of elevation, is recorded. The test is considered positive if radicular symptoms are reproduced in the contralateral leg. The patella apprehension test is performed with the patient supine and the knee flexed to approximately 30 degrees, with the quadriceps relaxed. The examiner presses along the medial aspect of the patella to exert a laterally directed pressure force. If the patient becomes uncomfortable and/or apprehensive, the test is considered to be positive. The valgus stress test is performed with the patient supine on the exam table. The knee is flexed to approximately 30 degrees of flexion. The examiner places one hand about the lateral aspect of the knee and grasps the ankle with the other hand. A valgus force is applied to the knee. In a positive test, there is asymmetric laxity and a lack of a firm endpoint, suggestive of a medial collateral ligament tear of the knee. The varus stress test is performed with the patient supine on the examination table. The knee is flexed to approximately 30 degrees. One hand is placed about the medial knee and the other grasps the ankle. A varus force is applied to the knee. In a positive test, there is asymmetric laxity when compared to the opposite knee. The anterior draw test is performed with the subject supine, the hip flexed to 45 degrees and the knee flexed to 90 degrees. The examiner sits on the subject's foot with hands behind the proximal tibia and thumbs on the tibial plateau. Anterior force is applied to the proximal tibia. In a positive test, there is increased tibial displacement compared to the opposite side, or a soft endpoint. This is indicative of an anterior cruciate ligament tear. The posterior draw test is performed with the subject supine, the hips flexed to 45 degrees, and the knee flexed to 90 degrees, with the foot in neutral position. The examiner sits on the subject's foot with both hands behind the subject's proximal tibia and thumbs on the tibial plateau. A posterior force is applied to the proximal tibia. Increased posterior tibial displacement as compared to the uninvolved side is indicative of a posterior cruciate ligament tear. The Lachman test is performed with the patient supine. The knee is held in approximately 15 degrees of flexion. The femur is stabilized with one hand, while firm pressure is applied to the posterior aspect of the proximal tibia in an attempt to translate it anteriorly. Increased tibial displacement and/or a soft endpoint is indicative of an anterior cruciate ligament tear. The McMurray test is performed with the patient supine. The knee is first fully flexed with the foot held by grasping the heel. The medial meniscus is assessed with the tibia externally rotated, while the lateral meniscus is assessed with internal rotation of the tibia, with varying degrees of knee flexion. A painful click or thud is considered a positive test. The Taylor tilt test is performed with the ankle in slight plantar flexion. The examiner stabilizes the tibia and passively inverts the ankle. Asymmetric laxity and/or a lack of a firm endpoint is suggestive of a ligament tear. The syndesmosis squeeze test is performed by manually compressing the fibula to the tibia above the midpoint of the calf. A positive test produces pain over the area of the syndesmotic ligament. The anterior draw test of the ankle is performed with the ankle in a neutral position. The examiner stabilizes the tibia with his top hand and grasps the calcaneus, moving the talus forward in an anterior direction. Asymmetric laxity is suggestive of a positive test.